right now we're going to start our third session. Actually, it is the last but not the least, and it is the main session for our meeting today. And it will be liver transplantation, sharing the experience.
It's our pleasure. The first talk will be by Dr. Tawhida Yassin. Dr. Tawhida is a professor of pediatric hepatology and liver transplantation, Faculty of Medicine at Shams University, and Yassin Abdel Ghaffar, Charity Center for Liver Disease and Research, Cairo, Egypt. Professor Tawhida is a member of the European Society Association of the Study of Liver Disease, member and the chairman of the Society of Friends of Liver Patients in Arab and World, editor-in-chief of Egyptian Liver Journal, and fellow of the American Association of the Study of Liver Disease. Dr. Tawhida's talk will be about the role of liver transplantation in management of inborn error of metabolism. The floor of yours, Dr. Tawhida. Dr. Tawhida will join us by Zoom because she's ill. سلامتك دكتورة توحيدة.
السلام عليكم جميعا ومساء الخير. أنا السلايدز باينة ولا مش باينة؟ أنا عاملة سلايد شير. السلام عليكم.
عليكم السلام دكتورة توحيدة، سامعين حضرتك.
السلايد شير باينة؟
لا لسه.
أنا عاملة سلايد شير. أوكي. كده. مش باينة برضو؟ بس سترينج. مش باينة برضو يا دكتورة سلاف؟ دكتورة سلاف مش باينة السلايد شير؟
لا لسه ما بانتش يا دكتورة توحيدة.
أنا مجربة قبل ما أجي. غريبة يعني. طب مش عارفة أعمل إيه. مش عارفة أعمل إيه.
دكتور حضرتك
نعم.
معايا؟ إحنا شايف حضرتك بالفيديو ثانية واحدة. بس إحنا السلايد حضرتك ممكن تعملي شير سكرين؟
أنا عملت شير سكرين أهو.
طب ممكن حضرتك تقفلي شيرنج؟ يعني حضرتك مش عاملة شيرنج.
لا أنا عاملة شيرنج، أنا عاملة شير سكرين.
ثانية واحدة.
عاملة شير.
أيوة
كده باين؟
كده حضرتك عملتي. ممكن بقى تعملي فول سكرين مود؟
حاضر. كده بانت؟
كده تمام دكتورة توحيدة.
طب الحمد لله. السلام عليكم. ابتدي؟
اتفضلي حضرتك.
اتفضلي.
طيب شكرا. السلام عليكم جميعا. متشكرة جدا انكم اتاحتوا لي فرصة ان انا اقول التوك بتاعتي in spite of being not able to attend in person. thank you very much for the organizers الأستاذة الدكتورة سلاف والأستاذة الدكتورة علا وكل التيم بتاع inborn errors of metabolism. thank you for the chairpersons and for the introduction. My talk will be on liver transplantation for liver-based metabolic diseases. وإحنا عندنا metabolic diseases constitute around 20% of the indications of liver transplantation in our cohort of patients. أو بالضبط 17.6%. Usually in the literature, metabolic liver disease أو inborn errors of metabolism constitute the second most common cause of liver transplantation after cholestatic liver disease. We consider that liver transplantation is a comprehensive solution if it results in complete cure of the disease for which it was undertaken. يعني اللي بعد ما نعمل transplantation خلاص الديزيز هيروح هيبقى فيه complete cure. But if it ameliorates but does not cure the disease, or if the extrahepatic complications related to the disease progress and do not regress after liver transplantation, then it is not a comprehensive solution. It just is an ameliorating solution, not a comprehensive cure. Usually it is curative if the defect is expressed exclusively in the liver. يعني ال genetic defect أو protein produced is expressed exclusively in the liver. مش موجود في any other site. زي إيه؟ زي عيانين الويلسون's disease, alpha 1 antitrypsin deficiency, regular Najjar type 1, and so on. We then are going to classify diseases that are liver-based, metabolic liver diseases, into 3 groups. في الجروب الأولاني, the defect is based in the liver, and it affects both the structure and the function of the liver. It's based in the liver and affects the structure and function of the liver. زي Wilson's disease, زي tyrosinemia type 1, زي alpha 1 antitrypsin deficiency. But in the other group, اللي هو group 2, the defect is again based in the liver, but yet it does not affect the extrahepatic sites it affects the extrahepatic sites without affecting the liver. يعني it is الجيناتيك defect موجود في الليفر واكسبريسد في البروتين اللي بيطلع expressed في الليفر، لكن الافكشن الليفر is completely normal. Function wise and structure wise it is completely normal. مال البروتين ده كان هيشتغل فين؟ في extrahepatic sites، وبالتالي الافكشن الليفر affection او I mean the disease is expressed in the extrahepatic sites without affecting the liver. زي ايه؟ زي regular Najjar type 1 احنا عارفين بيبقى فيه indirect hyperbilirubinemia sorry بيبقى فيه indirect hyperbilirubinemia، لكن الليفر نفسها is completely normal. في الهوموزايجوس familial hypercholesterolemia بيبقى فيه برضه increased في الكوليسترول level very big rise in the cholesterol level، والديفكت موجود في الليفر في الهيباتوسايتس، لكن الليفر فانكشن والليفر ستراكشر از كومبليتلي نورمال. وده ينطبق على حاجات كتيره، منها type 1 hyperoxaluria، منها MSUD organic acidemias and so on. In group 3 the defect is in the extrahepatic site mainly or sites and causing a systemic disease of which the liver is a part. هنا the liver is not the only site of expression of the defective gene. It is present in different sites, and the liver is part of the systemic affection. زي في Gaucher's disease، زي في cystic fibrosis، زي في CDGs MP1 CDG. When are we going to do? When is the patient candidate for liver transplantation? It depends upon the group اللي فيه الديفكت classified فيه. يعني in group 1 where there is a structural and functional defect in the liver transplantation candidacy depends upon the extent of liver affection. If the liver is mildly affected, there will be no need for transplantation. But if it is an end-stage liver disease, then we'll have to transplant. And of course, about the availability of the medical options. For instance, in Wilson's disease, we have a medical option, which is the chelators, the penicillamine and others. So we don't resort to transplantation, except if these are not available or they are non-effective. Also, depends upon the susceptibility to malignancy. يعني في بعض diseases are highly susceptible to malignant transformation. زي tyrosinemia مثلا. There is a very high susceptibility to malignancy. And this is in itself is an indication for transplantation, even if the liver condition is not terminal. And again, the extent of extrahepatic involvement. If there is major extrahepatic involvement, transplantation will not save the other organs. So we have to interfere at a proper time before the extrahepatic involvement is severe. And upon recurrence of the disease, what's the use of doing a transplantation if we are going to have a recurrent disease? We're going to have a quick look on the group 1 conditions, including Wilson's disease, which is an ATP7B gene mutation, and the protein the protein which is encoded by the ATP7 gene resides in the hepatocytes. Thus, liver transplantation, when indicated, corrects the underlying problem and is curative. When you transplant a patient with Wilson's disease, you don't have to give any more chelators. You don't have to treat any more the Wilson's condition. The point here is that the effect on neurological symptoms has been controversial. Wilson's patients sometimes present with neurological manifestations. So are we going to transplant those patients who have neurological symptoms or not? It has been controversial, and it really depends on the extent of neurological affection. Because in a recent systematic literature review of 48 articles showing outcome after liver transplantation in around 300 patients with neurological manifestations, the conclusion was that major neurological improvement was reported in around 3/4 of the patients. But yet worsening was reported in about 10%. So again, it's very controversial. Are you going to transplant this patient who has neurological symptoms or not? It depends, as I told you, about the extent and duration of the neurological affection. If it was a very marked neurological disease, we don't expect that the transplantation will improve him. So this is the controversial part in Wilson's disease. Another thing is the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is produced by the liver. It protects the lung from the effects of neutrophil elastase. It works outside the liver. Yet, if the produced alpha-1 antitrypsin accumulates within the hepatocytes, then there is this protein, this abnormally misfolded protein, will result in liver disease. Not all patients with alpha-1 antitrypsin deficiency produce this protein. Sometimes the protein is not produced at all. It's a null alpha-1 antitrypsin deficiency. It's a null phenotype. In that case, there is no liver affection. The liver functions very well. But in case of the PIZZ or the PI sometimes MZ, they produce a misfolded protein which accumulates within the hepatocyte and is not able to leave the hepatocyte to get into the circulation. So in that case, liver disease is going to occur. And long-term, it has been found that long-term results of liver transplantation have shown excellent graft and patient survival rates. We don't have alpha-1 antitrypsin deficiency in our community, in spite of being of a major metabolic condition in Europe. We haven't transplanted any patient for alpha-1 antitrypsin deficiency. Yet some studies have shown an unexpected decline of FEV1 in some patients who have been transplanted. So this is another controversial point here. Although the liver becomes completely normal after transplantation, and it has been expected that the lung also improves, yet some studies have shown that there is an unexpected decline in the FEV1 in some patients. Then we come to hepatorenal pyrosemia. Hepatorenal pyrosemia, as we all know, is a condition that results from deficiency of the FAH, fumarate acetate hydrolase, with resultant increase in succinyl acetone and fumarate acetoacetate. Of course, this is going to result in both kidney and liver affection. So and sometimes neurological affection as well. When is the patient indicated to undergo a liver transplantation? If he presents with acute liver failure, then this especially occurs in infancy. So this is a clear indication of liver transplantation in that case. If there is an HCC if we find that the patient comes with a possibility of HCC. If there is resistance to NTBC, because here we have a presumed cure for tyrosinemia, which is NTBC, which acts at this level, causing or preventing the accumulation of humoral progression of the metabolism and the formation of humoral acetate. So it should be a treatment. It was expected to be a complete cure or a complete treatment, but actually it is not, because if it is not given in the proper time in very early infancy, in the first year of life, the effect on production of HCC or development of HCC is not sure. We were not sure that HCC will not develop. And there are reports that even children, very recent report from Australia, that children who have received the NTBC in their infancy, 3 of them developed HCC in childhood, even at the age of 13 years, developed HCC in spite of receiving continuous, uninterrupted NTBC treatment since infancy, which raises the big question of should we transplant or not transplant patients with tyrosinemia who have cirrhosis. The cost and the availability of NTBC is another factor, because if you give an interrupted treatment, the patient could develop a neurological crisis. And we have faced this. We have been giving NTBC to some of our patients some years ago, based on we get the cost from donations. And if the donations are not available or the drug is not available, we stop the drug. And we had one of our patients developing neurological crisis, and unfortunately passed away because we were forced to stop the drug because it was not available. These are some of the livers of patients from who have been transplanted for tyrosinemia. You can see how bad the liver is, full of nodules. And there's this big nodule, which has in the dynamic study, in the MRI, it was stated as possibility of HCC. Now, our experience in liver transplantation for hepatorenal tyrosinemia, they were in 2022, they were 8 patients. Now they are 10 patients. Their ages are between 2 years and 12 years. And in 7 of them, there were focal lesions with HCC on dynamic study in 5 patients. After transplantation, the height improved markedly, the INR improved, the alpha-fetoprotein dropped to normal levels, and the serum phosphate increased, because they have hypophosphatemia usually because of the renal affection. Succinyl acetone dropped markedly. You know, succinyl acetone is the diagnostic, biochemical diagnostic parameter. But it dropped markedly, but it did not reach the negative. It was not negative except in 2 patients. In the other patients, it dropped markedly, but still was succinyl acetone excretion in urine was still positive, in spite of being much lower than before transplantation. We studied the renal function in some of our patients, and again, cystatin C, which is more relevant in transplanted patients than creatinine. Cystatin C was high in 3 patients, denoting some renal affection, and also urinary beta-2 microglobulin was again high in 3 patients, again denoting renal affection. And these are patients, some of them have been transplanted 5 years before taking the test, 4 years, 3 years before they're taking the test, and so it's a long-term thing. The Canadian US consensus meeting recommended that post-transplant patients should have periodic screening for renal disease. So in hepatorenal tyrosinemia, we can see that liver transplantation cures completely the liver condition. The liver condition is completely cured, yet still succinyl-acetone could be detected in the urine of most of the patients. Long-term renal monitoring is advised, whether to use NTBC post-transplant with this succinyl-acetone excretion, in spite of it being minimal. We don't know in the very long run how things are going to be, but using NTBC post-transplant is still controversial, and we do not use it up to now in our cases. Then we come to the glycogen storage diseases. Again, these are a wide range of diseases, but we have the hepatic glycogen storage diseases, which are type 1, 3, 4, and 6. Liver transplantation is indicated if there is cirrhosis. Which of these produces cirrhosis? It's of course type 4, but again, some of type 3 patients develop cirrhosis and some of type 6 patients develop cirrhosis. Liver transplantation is indicated if there is cirrhosis. Poor metabolic control is as well an indication for liver transplantation. مين اللي بيبقى عندهم very bad metabolic condition type 1 type 1 GSD هم أوحش ناس في GSD في الميتابوليك كنترول بتاعهم. Type 1ism are indicated for liver transplantation if they have poor metabolic control in spite of all our trials to control them well. The outcome as regards survival is comparable to that of liver transplantation for any other disease. They have good outcome compared to any other liver transplantation for any other disease. Yet there are special considerations that have to be put in mind. Long-term renal outcome in GSD type 1A has been understudied, or is understudied. There are reports that the patients who have been transplanted for GSD type 1A, of course we know that type 1A affects the kidney as well. So it has been found through long-term studies that most of the patients who have been transplanted for GSD type 1A develop normal renal functions and the renal condition does not progress, except in patients who have received their cornstarch after the age of 6 years. Yani, who have been diagnosed with GSD type 1A and received medical management later on in life, not in early infancy. In this case, the renal condition could progress and not regress. Also, post-operative management in the early post-operative management in GSD type 1B should be individualized because they have neutropenia and neutrophil dysfunction, and we are using immunosuppression. So we are exposing them to more bacteremia and more bacterial infection. That's why in the early post-operative, they have the immunosuppression management should be tailored to their condition. And a very good eye should be put on the infection and the cultures. Also, there is a possibility of evolution of the cardiomyopathy and the myopathy that occurs in patients with glycogen storage type 3. We know that glycogen storage type 3, many of them have myopathies and cardiomyopathy. And there are some reports that the cardiomyopathy and the myopathy post-transplantation could evolve and could, transplantation does not stop the evolution of the cardiomyopathy and the myopathy post-transplant. But I want to draw your attention to the fact that studies on this group of patient transplantation, this group of patients is very limited because of the limited number of children that have been transplanted as glycogen storage disease patients. All of these were examples of conditions that are all in group 1, where the liver affection is the main thing. There is liver affection as regards the function and the structure of the liver. Then we come to the group 2, where liver affection, there is no liver affection in the sense of no change in the function or structure of the liver. Yet there is a disease outside the liver, which is caused by a gene defect inside the liver. So when we come to address these conditions for the possibility of transplantation, we have to answer the following questions. Will liver transplantation cure the condition, or will it only ameliorate the condition? Will there be the residual effects after transplantation, or will we, by transplanting this patient, have no effects whatsoever for the extra hepatic manifestations of the disease? Timing of transplantation is very important because, for instance, in homozygous familial hypercholesterolemia and in primary hyperoxaluria, if you don't go for the proper timing, you will have cardiac affection and a cardiac failure where we can't transplant. And in the case of hyperoxaluria, renal disease will be evident. End-stage renal disease would be evident, and we'd have, in that case, to transplant both the liver and the kidney. Careful perioperative management is necessary because of the significant catabolic effect of surgical stress. Metabolic decompensation can occur, especially in such cases as the amino acidoprotease, organic acidoprotease, and the MSUD, and so on. The question of using parents as potential donors because we in our country, we only do living-related transplantation. We depend upon the living donors, the parents and the relatives. So there is a question of using parents as potential donors if they are obligate carriers, of course. We have some experience with homozygous familial hypercholesterolemia, which is an autosomal dominant disorder that causes marked rise in cholesterol and LDL cholesterol with normal triglycerides. Mainly it's because of absence of the LDL receptors in the liver. 70 to 75% of the LDL receptors reside in the liver and are the primary determinants of hepatic uptake of LDL. In homozygous familial hypercholesterolemia, the impact of diet management is negligible. Diet has no effect. Statins result in only 10 to 20% reduction of cholesterol. Cholesterol here is 800, 700 milligram percent. We are going to reduce it by only 10 to 20% when using statins. LDL apheresis results in 50% reduction, but it has to be repeated every week or every 2 weeks. And it's very expensive, and we don't have in Egypt the filters for the LDL when using apheresis. These are some of our patients with LDL or homozygous familial hypercholesterolemia. You can see how high the level of cholesterol is. They even come, their ages are 5 years, 3 years. And their echoes shows even mild aortic stenosis in one of them, thickening of the aortic cusp even at this age, 3 years, 5 years, they have these atherosclerotic changes. And these are the xanthomas you find, the arcosemias you find. These are our patients again. Unfortunately, after liver transplantation, you can see the rapid and marked drop in the cholesterol level, but yet it didn't reach the normal level except after adding statins. Because when you add statins at this level, you can, by the 10% reduction that the statins produce, you can move from this above the level to below the level of normality. So in these patients, at the beginning of transplantation of these patients, we didn't use statins. We thought that it is enough to transplant. Later on, because we knew that still there is a part of the LDL receptors which are not present in the liver and which are still not capable of taking LDL because they are abnormal. And so from experiencing the effect in the patients, we started to use statins. Here you see that there is a big lapse of time between transplantation and using statins in this first patient. But after that, we used statins very early after transplantation to get the level below normality, or at the level of normality. So liver transplantation rapidly reduces the cholesterol level, the xanthomas disappear, but arcus senilis does not disappear, which is very strange. But it does not normalize the LDL cholesterol level, and patients should be maintained on statins. The donor should not be the parent because this is a codominant condition, and timing should be before major coronary artery affection. MSUD, maple syrup urine disease, in MSUD there is an enzymatic defect in the catabolic pathway of branched-chain amino acids. Unlike other amino acids, the majority of function of the enzyme complex is in the skeletal muscle, 66% in the skeletal muscle, not in the liver. الليفر metabolize 9 to 13% only, while the skeletal muscles are the main site of production of metabolism. 10% of function. الكلام ده هيبقى مهم لما نيجي نتكلم على حاجه اسمها domino transplantation later on. 10% of the function of MSUD of the enzyme is sufficient to maintain the peripheral amino acid homeostasis. You don't need the whole 100% of the enzyme. You need only 10% of the function. The first report on 11 patients transplanted for MSUD, يعني خلي بالنا هنا الليفر فيها كمية قليلة، 66% موجودين خارج الليفر، لكن جوه الليفر كمية قليلة ranging between 9 and 13%. We need only 10%. فإذا الليفر could be transplanted. When transplanted, it could ameliorate and even cure the condition. The first report on 11 patients for MSUD was in 2006. Branched-chain amino acid levels normalized within 6 hours and remain normal on an unrestricted diet. So there is no need, when you transplant an MSUD patient, you don't need to restrict the diet anymore. You can see here that 100% of the patients, there is 100% graft and patient survival. Leucine tolerance increased tenfold. Branched-chain amino acid levels were corrected within hours and remained stable. This is true, but yet during the operation itself, this is a very high metabolic stress. And during the operation, they have to be maintained on high lipid and high glucose. And they have to, the metabolic specialist has to be involved. None of the patients stopped his medications for hyperactivity because the neuro affection was not, the mental affection was not completely corrected. Amino acids should not be monitored should be monitored during catabolic illness. يعني لما بيحصل that during the resting state. But when there is a catabolic illness or catabolic condition, amino acids still should be monitored, because in that case, still you have to give a restricted diet. Any compromise in hepatic blood flow could compromise the clearance of the branched-chain amino acids. يعني هنا we have always to maintain a good hepatic blood flow. And that's a very interesting thing. MSUD livers can be used. These are healthy livers, remember? They are healthy livers. There is nothing wrong with the function or structure of this liver. But you took it away from this patient because he had MSUD. When you put it in a patient, you can, if you take this healthy liver and put it for another patient who has end-stage liver disease, you take off his bad liver and put this new liver for him. This patient does not have this new patient, new recipient does not have MSUD. He has only end-stage liver disease. And he can produce the enzymes of MSUD, he can produce them through his muscles, because we said that the muscles contributes 66% of the metabolism. So he can produce the defective material through the muscles. So if you take this liver and give it to another end-stage liver disease patient, this is known as domino graft. This is a domino graft. You can save the life of this other patient without exposing him to developing MSUD, because he can produce it through his muscles. So MSUD livers can be used for domino liver transplantation. In their follow-up report of 6 domino graft recipients, Mazarigas et al. Have shown that they had 100% survival and normal branched-chain amino acid homeostasis. They did not develop MSUD. Another more recent report on 11 MSUD children confirmed the results, the previous results. So MSUD explant can even be used for domino split liver transplantation. You can give it to 2 patients, not only 1 patient. That the MSUD liver can be given to 2 patients, not only 1 patient. This is very interesting for the liver transplantation. In mitochondrial hepatocytes, transplantation is very controversial, because even in those with primary hepatopathy, primary mitochondrial hepatopathy or single gene defects, زي مثلا النافاياجو hepatopathy or these mutations, the overall survival was very low. The survival benefit is very bad. It's only 47%. So it's very sad that you cannot transplant a patient who has liver disease, because you know that if you transplant him, even if he doesn't have now a neurological disease, there is a big possibility that he's going to develop the neurological disease. The only exception is sometimes when the patient presents in early life with liver failure, acute liver failure, and you're not sure if this acute liver failure is a mitochondrial condition or not. In that case, you have to run for WES testing, whole exome testing, before transplanting. I'm not going to talk about the urea cycle defects or the organic acidemias, because I know that there are people, other great professors who are with high expertise in these conditions, who are going to tackle them. So to wrap up, liver transplantation is the cure of metabolic-based liver disease whenever the defective protein resides exclusively in the liver. In other cases, liver transplantation ameliorates but does not cure the metabolic defect. It thus may improve the quality of life. Many of the metabolic diseases involve more than one organ and need special metabolic considerations that the decision to transplant, as well as whether to transplant or not, as well as the pre-operative preparation, the intra and post-operative early and late care should involve an MDT that includes the inborn error of metabolism specialists and the different relevant specialities. Thank you very much. I hope I wasn't too long here.
Thank you, Professor Dr. توحيدة. حضرتك تحبي الأسئلة دلوقتي ولا حضرتك تستني معانا لآخر السيشن؟
زي ما تحبوا، يعني لو في أسئلة يا ريت.
أنا عشان بس حضرتك عيان، عشان كده قلت لو في أسئلة ممكن نسألها دلوقتي.
زي ما تحبوا يا whatever you like, whatever is convenient for you. يعني لو خلصنا دلوقتي يبقى أضمن يعني. هو النور عندي وحش قوي ولا إيه؟ أنا مش شايف.
Okay. So it's my pleasure to present Dr. Professor Mohammed Shagrani, Professor and Consultant of Pediatric Hepatology, the Section Head of Pediatric Transplantation, Gastro and Hepatology at King Faisal Specialized Hospital and Research Center, Saudi Arabia. Professor Mohammed will share with us his great experience in the outcome of liver transplantation for urea cycle disorders in King Faisal Specialized Hospital, and then he will share his experience about the outcome of liver transplantation for organic acidemia in the same institution. The floor of yours, Dr. Muhammad. Thank you.
السلام عليكم ورحمة الله. بسم الله والصلاة والسلام على رسول الله. أولا أنا شاكر ومقدر للدكتورة علا والدكتورة سلاف والorganizing committee for the invitation. I know it is the end, so we don't need to have really a heavy talks like this. But the good thing that many things has been covered, so I will try to wrap both lectures in one talk. Inshallah, it will be very short. So mainly, as Dr. Ula, and I would like really to thank her on the behalf of King Faisal for the time she's spending King Faisal. So the liver transplantation has been started in King Faisal as a pediatric group in 2011. And since I joined in 2012 and 2013, this is the time I decided that we need to start transplanting metabolic patients. So I have nothing to disclose. You know this, you know the urea cycle disorder. You have the CBS1, the OTC, and cytoanemia type 1, arginosuccinic, ARG, and NAGS. I will bypass this slides. This is just to show that patients often present with severe neonatal onset, and despite the increase in the awareness and evidence-based recommendation for metabolic management using dietary treatment and pharmacotherapy, still the long-term clinical outcome of affected individuals are often poor. So all UCDs are monogenic, autosomal recessive disorders, we know that, except the ornithine transcarbamylase deficiency inherited as an X-linked manner. And this is very important information because we are running mainly a living-related program. So in cases of ATC, we don't take the mom as a donor because we know that the enzymatic replacement is not enough, and most likely the mom will present with the disease and manifest the disease if she donates. The neonatal onset of ATC could be a clear indication for liver transplantation as soon as possible, because usually those neonates, if they have recurrent attack, they will have really very bad brain insult. This is our publication. I published our genetic profiling of children with advanced cholestatic liver disease, and this has been done in 2017 with Professor Fawzan, and at that time we showed really that we have a very high carrier rate in our society, and I'm sure Egypt and the rest of the Arab countries are the same. So if you look for the carrier screening, we have 1 in 7,000, and this is really too much and worry us about the future that we will have more and more genetic diseases. So this is one of the guidelines. This guidelines has been published to cover the whole Middle East in the management of hyperammonia. And this suggests guideline aim to ease the challenge faced by physicians dealing with acute hyperammonia in the region. In addition, guidelines have demonstrated useful collaboration between experts in the region and provide information that will hopefully improve the outcome of patients with acute hyperammonia. And King Faisal and Dr. Ula were part of this. This is one of the data which is looking across the USA for 260 patients of UCD, and it showed 142 have OTC, followed by arginosuccinic 55%, and the least are the arginase deficiency less than 1%. 50% of the patients were alive at 5 years. Mortality seemed to correlate closely with age at presentation, which is very clear, with the newborn group having the lowest survival statistic. These data also justify the consideration of alternative therapy, such as orthotopic liver transplantation in those enzyme deficiencies such as OTC and CFS1 that present in the neonatal period. And this is very important, showing you that even with the guideline, with the pharmacotherapy, with the diet therapy, still some of those children showing very bad prognosis. This is another longitudinal study of the urea cycle disorders, and it found biologically evident that both glutamine and ammonia have effect on the brain function, that each molecule may affect the brain in different ways. There is also evidence that the effect of UCDs are more systemic than had been recognized previously. I will show you this is also in our data, including causing liver disorder and perhaps even liver cancer, as well as kidney and vascular pathology by changes in the metabolism of nitric acid. And I will show you unpublished data about how arginosuccinic aciduria can affect the liver and cause genuine liver disease. So there is some preliminary evidence that improved understanding of UCD pathology and improved access to information in UCD's management, as well as early diagnosis through newborn screening, have had a positive impact on mortality and morbidity. So this is another cross-sectional multi-center study of patients with urea cycle disorders in the USA, and it showed more than half of the enrolled patients had normal urological examination, while others had a variety of abnormalities such as tone, reflex abnormalities, or abnormal involuntary movements. So liver transplantation has been applied with the aim of permanent enzyme replacement and hence rescue UCDs with the transplant organ. Organ transplantation aims to improve patients' metabolic control, so reduce the occurrence of metabolic decompensation, which is affect their brain. And number B, which is very important, is improving the quality of life. And this is always controversial. Everyone can see it from different angles. So sometimes when you have a UCD patients, we need to first assist them for what is their really neurological status. If they have already disability, if there is already uncontrolled seizures, then really you want to discuss this with the parents, because you will end by doing living-related liver transplantation. So you want to really the family to understand that you will stop actually the disease at this stage, but the improvements in the future this is really very controversial. In the United States and in Europe, young UCDs patients, by default, they receive a preference on the waiting list, for example, high pediatric model for end-stage liver disease. What the meaning of this? They consider metabolic disease like UCDs or propionic acidemia or MMA as really top on the list for the cadaveric organs, and they give them very high score as 30, like those with the sick liver patients who's having cirrhotic liver disease. Organic acidemia, we have propionic acidemia, MMA. Both of them, they are the most common organic acidemias and account for profound morbidity in affected individuals. Liver transplantation has emerged as a bulk enzyme replacement strategy to stabilize metabolic fragile patients and to prevent the occurrence of long-term complications. And this is very important. When we are talking about UCDs, we said will cure most likely the disease, but when we are talking about organic acidemia, we are saying that will be just enzymatic replacement bulk. So it's mean that even when you do liver transplantation, those patients with PA or MMA, still they are at high risk of recurrence, especially when they are having any intercurrent illness like diarrhea, vomiting, fever, or sepsis. Some of them will manifest the disease. So successful liver transplantation or kidney transplantation procedure have prolonged survival and resulted in a better quality of life, lowering urine plasma MMA level, but still much higher than normal, reduced onset of metabolic stroke, occasional improvement developmental delay, and relaxing the protein diet. Quickly about maple syrup disease, Dr. Tawhida mentioned about the complexity of the disease. We know that there is different phenotype, and in liver transplantation, we are talking about the classical neonatal. She mentioned about the Dimino liver transplantation. So usually those liver can be utilized and can be transplanted in adult or pediatric, but usually you need to choose the right patients. So usually we look for those patients, they don't have muscle disease, they don't have muscle wasting, and they don't have renal disease, because this is the other two organs which will compensate the MSUD in the MSUD graft recipients. This is one of the study which is looking for a big group of MSUD, and currently I have been invited to Lisbon, and this is the sub-network of European Reference Network for Hereditary Metabolic Disorders. They are running a meeting every year. So last year we have been in Lisbon, and currently people working in making guideline for best liver transplantation in UCD and in organic acidemia. At the same time, now they are running a Dimino, MSUD Dimino graft registry. Post-transplantation outcome in patient with PA and MMA. I will compare our data to this data which has been published in 2020, and the conclusion: liver transplantation and combined liver-kidney transplantation appeared to benefit some patients with PA or MMA respectively, but this approach does not provide complete correction of the metabolic defect, and some patients remain at risk from disease-related and transplantation-related complication, including death. Thus, all treatment avenues should be exhausted before consideration of organ transplantation, and the benefits of this approach must be weighed against the risk of preoperative complication on an individual basis. I brought this paper because it has been written by metabolic doctors who are against liver transplantation, no pediatric hepatology, but always we need also to listen to compare. So this is our indication of pediatric liver transplantation. So far we reached 800. At the time I was working on this data, we were around 700. You can see that most of the indication in our data are familial or genetic liver diseases. Still biliary atresia is a common, but if you look to our data, we have all the type of BIFIC disease from 1 and to 8. As you know, we are the first center who reported the BIFIC type 7 and BIFIC type 8 as a novel gene has been published from our center. And this is really related for intrafamilial marriages. In one data, the intrafamilial marriages in our society is around 65%. And as I told you, we make a calculation for the carrier rate in our society, and it is 1 in 7,000, which is very, very high. So this is our own data now. So the inclusion criteria: confirmed diagnosis of urea cycle disorder or organic acidemia or MSUD based on genetic and enzyme. Patients were treated before transplantation with aggressive control of hyperammonia, including protein restriction, citrulline or arginine supplementation, and ammonia scavenger, and the rest. We do full neurological evaluation before liver transplantation, including EEG and brain MRI. Swallowing study, modified barium swallow. This is very important, especially on MMA and PA, because some of those patients, they have really swallowing problems. So you wanted to do rehabilitation, like fundoplication, GT tube before transplantation. Otherwise, you will suffer from the aspiration pneumonia post-liver transplantation. And now this is a mandatory in all of our patients, especially the organic acidemia. So we have total so far transplanted 92 patients, arginosuccinic 26, cytonemia 13, MSUD 23 patients, PPA 28, MMA 2 patients. For the MSUD, this is just a very quick slide. The total number of patients, we did 23 patients between 27 to 2023. The domino graft utilization, we utilized 70%. First domino we did was in 2019. We used the domino in 4 adult recipients and 13 pediatric recipients. The 13 pediatric recipients, Alagille syndrome, hepatoblastoma, biliary atresia, BIFIC2, and familial hypercholesterolemia. The MSUD patients' 5-year survival rate so far is 100%. The graft survival 96. We have 1 retransplant due to biliary stricture and chronic rejection. The MSUD graft domino recipients, 4 years actuarial survival rate is 92. 1 died as a case of familial hypercholesterolemia. We are saying query to MI or outflow obstruction. So, do we have a specific protocol for those UCDs and organic acidemia? Actually, over the years, we were learning because the first UCD case we did in 2013, so almost now it's 11 years. So usually the night of liver transplantation, we continue them in the same as pre-transplant, and we give them high dose dextrose. Some of them, we never reach more than D10. In some patients, we require more. The NPO, we make it maximum 6 hours. Same management in PICU with the close monitoring. No need for special diet after transplantation. And over the years, we saw some cases of arginosuccinic. This is just our own experience. We have no evidence base of this. They start to have recurrent sepsis post-transplantation, especially the arginosuccinic. So after we putting them on a very small dose of arginine, they never come back. So we think that there is a need of arginine in those patients coming with recurrent sepsis, especially the arginosuccinic. The post-transplantation protocol, actually, we have nothing specific. It is the same like all other cases. Our protocol has 2 days of basiliximab, day 1 and day 4. We give IV methylprednisolone. This is during the anhepatic phase. And usually we are running a low steroid protocol post-transplantation. I changed our protocol since 10 years to be just 20 milligram per meter square. Basiliximab was given 8 hours after a reperfusion, and then at day 4. Diet, we have relaxed protein diet for those patients, and I mentioned about the arginine in those with recurrent infection. Pre- and post-transplantation protocol for organic acidemias. In organic acidemia, the night of liver is the same. Some of them really required more than D10. To be honest with you, when we start to do PA, we looked to the literature from everywhere, and we found a lot of articles talking that you need to have a special management intraoperatively. You wanted to talk to your anesthesia and your surgical team. Some of those anesthetic drugs, they have been mentioning that maybe it will cause decompensation. But to be honest with you, after we did 22, we didn't see anything of this. We prepare our anesthetics. We have all the scavenger medication in case of hyperammonia. Everything is ready. But really, if there is no bad surgical complication and the child not in a stress intraoperatively, most of the time nothing is happening. In my opinion, those metabolic patients, when they have a good, smooth surgical course, actually they have been extubated in table and they came to the ICU extubated. Because you are sending patient who's not sick, not like those cirrhotic, who's having ascites, who's having portal hypertension. I mean, they are totally different. They look completely normal post-transplantation. The only issue will be because we are running a living-related program that some of them will require to have a mesh. You cannot close the abdomen day 1, and they will require maybe a week until you manage to close the abdomen because, the ascites is a friend for the surgeon for the abdominal closure. Carnitine boluses, usually it will continue at 100 milligram per kg per dose at Q6 to 8 hours. PICU with the close monitoring. We are ready for any CRRT and ammonia scavenger therapy, as I told you, but we never did. Partially protein restricted for 6 months. The medical therapy, in our experience, actually, we have some patients, they still running carnitine even after 3 years, and some of them has been stopped. So to be honest with you, our patient under different metabolic doctors, we keep our patient under their follow-up. So some of them who follow their C3, when they found that the level is low, he start to wean the medication, and some of them after 3 years, they are not. Some of them still, they are keeping them in a very small dose of carnitine. We have emergency protocol during intercurrent illness because we know those PA and MMA can develop actually crisis, especially when they have diarrhea or vomiting. So usually we have our own protocol that those patients, maybe they need a management like crisis. Most of the time what they need just high dextrose, and they never required any treatment, mild acidosis, but usually you want it to be ready because you shouldn't be surprised that they are coming with crisis. For post-transplant, renal sparing protocol is very important because we know those PA and MMA, they are very high risk for a renal disease even after transplantation. So usually within 3 to 6 months, we shift them to the renal sparing protocol, a small dose of tacrolimus with Cercept. So this data is from April 2011 until October 2023. The total number of pediatric liver transplant recipients with MSUD, as I mentioned, 92. Age at transplantation, our mean is 3.6, the median is 2.7, and you can see the reason for that we transplant one child at the age of 17. And still, the age is very important because if we do believe as a pediatric hepatology and as metabolic that those patients with recurrent crisis, they will have a brain insult. If we believe that the level of ammonia is very important, and whenever you have recurrent hits to your brain with ammonia more than 300, most of the time you will have really a permanent brain affected, then actually sending those patients early for liver transplantation is much, much better than delaying the liver transplantation. In some cases, even we put a protocol with our metabolic colleagues in the whole now kingdom that even if you know the genotype, and you know that this genotype will have a severe phenotype presentation, there is no point to wait for crisis to send the patients, because your aim of doing liver transplantation of those metabolic patients, not to improve the quality of life for the family, you wanted to have independent individuals. Otherwise, you will transplant a group of patients who will be ended to be a CP. I don't think so. You will add a lot. And when those children, they will be an adult and they will have any reason for retransplantation, allograft fibrosis, chronic rejection, most likely our adult colleague will not consider them for retransplantation. So we need to act on this, and I think the age is very, very important. So living related, you can see that we did 90 child as living related, so the rate is 97, and 2 disease donor. We did 3 cases as EPO incompatible with little bit modified protocol, and I published our EPO incompatible modified protocol 2 years ago in liver transplantation. So this is our data, as I mentioned, sorry, that we have 91 alive, and the one who died, we have only 1 died from those with metabolic. You can see the highest rate maybe in bacterial, viral, fungal, because they calculate everything in our data registry, 23%. The risk of rejection is almost below the international data. We have 11.9%. So this is the ammonia level. We keep doing this just for academic and to keep a track. And you can see that they have normalized ammonia pre-transplantation. We look for the citrulline and citronemia, and almost for all of them it is below 500s. In the maple syrup disease, we look for leucine and isoleucine, as you know. And we look also for isoleucine and leucine in the domino recipients. But over 6 months, we found that all of them already normal. I'm talking about the domino recipients. For PA, we look for the C3 carnitine. Again, this is just showing you that here you are not curing the disease. It is going down, but never being normalized. The same things for methyl malonic acid. So this is just a quick about the histopathology finding in livers of patients with urea cycle disorder. As I mentioned earlier, that the arginosuccinic acidemia is really affecting the liver itself. And we found in our cases, we try to compare the urea cycle disorder explanted liver, and we found all the explanted livers were enlarged and appears grossly pale. Microscopic of the arginosuccinic cases showed glycogen hepatocytes with minimal steatosis and cirrhosis. The cytonemia case, however, is less glycogenated and less fibrotic. The electron microscopy of both genetic defects showed that there is ultrastructure damage, and we have 1 case of arginosuccinic who's having portal fibrosis and HCC. So actually arginosuccinic, and this is from our unpublished data, so in my opinion, arginosuccinic, other than it is metabolic, it is really causing a genuine liver disease. Independent of the defect in the urogenesis, liver involvement has been noted even in individual treated with protein restriction and arginine supplementation who had not experienced a significant hyperammonia. And in the last 3-4 years, we start to give more information for our adult colleague whenever they receive a consult as an adult transplant hepatology about arginosuccinic with portal hypertension with upper GI bleeding. Those patients, they develop a genuine liver disease and they should to go for liver transplantation. Currently, we are just trying to look for the serum bile acid in those patients, and until now, we will see if the serum bile acid can give you clue about the liver involvement in those arginosuccinic. So in conclusion, orthotopic liver transplantation could offer a therapeutic option in monogenic disease in 2 ways. One of them by substituting for an injured liver or by supplying a tissue that can replace a mutant protein. Liver transplantation may be only partially curative since abnormal phenotype is maintained by extrahepatic synthesis of the toxic metabolite, and this is the case in MMA and PA. Quality of life can be improved in almost all recipients, although neurological sequelae might remain in some individual, mainly in severely impaired children who has been referred late. Liver transplantation so far is the only effective treatment for MMA patient with recurrent metabolic decompensation, However, it is still possible that neurological and renal damage remains irreversible. Liver transplantation has role in the management of PA. It reduces the risk of metabolic decompensation and improves the quality of life. The potential for the development of metabolic sequelae is not completely eliminated. Our data strongly suggest that heterozygous living liver donor in the amino organic acid disorder does not affect the survival or the risk of crisis or long-term complication post-liver transplantation. And I think the same data should be here because we are transplanting all the time heterozygous to homozygous. Our data suggest that the use of a related donor in liver transplantation for MSUD was effective, and the liver of the MSUD patient was successfully used in domino transplantation for children with different liver disease, just being sure about renal and muscle disease. Survival rate with unrestricted diet are reported as 98.9 at 1 and 5 years survival. Gene therapy, this is the things which is we are all waiting for it, and this is the only disadvantage that people will talk to you. Can you do anything just to keep these children alive without any neurological problem? Because maybe the gene therapy will come. But again, with this crisis, with their brain insult, I think the gene therapy, it needs time until it will come. Thank you very much.
Thank you, Professor Chagrani. Very impressive as usual, and the results are very impressive. I think it's you and Sick Kids Ontario are the only two centers that have 100% survival after 5 years, as much as I know. I would ask you a single question. It's about the difficulty with the living related. You mentioned at the end the heterozygote. Is that your first choice when you have parents with metabolic liver, a child with metabolic liver disease? So it's an easy decision to have it's first choice to have one of the parents as a donor, or you first ask for another donor, maybe uncle or aunt who doesn't have the same.
Whenever we have familial hypercholesterolemia, even though it is doable, but you want to treat those parents because usually even if they are heterozygous, their cholesterol level above 10. So you wanted to do for them extensive cardiac workup, you wanted to give them a statin, you wanted to bring their cholesterol below the normal level before you will take them as a donor. We never did this, but there is already data published about transplanting heterozygous familial hypercholesterolemia to homozygous, and they require medication for 6 months. Dr. Tawhida mentioned about statin. In our data so far, we transplanted 14, none of them on statin, and all of them normalized their cholesterol. We never transplant them from carrier.
Maybe it's the statins because of the LDL receptors in intestine. It's deficient, and so that was our explanation why in our cohort we have some patients like that. Okay, last question. Sorry for the, but for the domino transplantation. You spoke domino transplantation. You spoke about the MMA, but what about the other metabolic diseases like hyperoxaluria and the Crigler-Najjar? There are some trials about that.
You mean you wanted to use them as domino grafts?
Yes.
Yeah. You know, the old data, first of all, if you go back to history, the MSUD, which has been transplanted for liver, nobody knows that liver transplantation will cure liver disease. The first case actually came to the science. Patient came with acute liver failure because of hepatitis A. And he has been transplanted as a fulminant liver failure. And then they found after liver transplantation that his crisis never happening. And then they discovered that doing liver transplantation, even with the limitation of the enzymes in the liver, is enough to cure the disease. And then the gate has been open for all other metabolic diseases. Taking Crigler-Najjar syndrome or taking actually hyperoxaluria, it has been done, especially hyperoxaluria, and it showed very bad result. So actually now Crigler-Najjar syndrome is out and primary hyperoxaluria is out because those patients, they went to renal failure because of the oxalate issue. So the only thing now people agree with it is amyloidosis if you have a case, which is very rare, or MSUD. And now there is some data came about using MMA as a domino graft, but mainly in adult. So even in our center, they were planning to start. I told them, listen, we have a very small number of MMA. We did 2 and this year 2, so total 4. I told them, if you wanted to offer it, I will never use it for pediatric patients because we don't know about those liver. If you wanted to use it for an adult with HCC who's having all those criteria that very unlikely to have a donor based on the cadaveric list, and there is no living-related donor. But until now, we didn't do any MMA graft as a domino graft.
What if you use it as a split, as a partial, keep the patient?
For the MSUD?
No, the MMA or whatever, you may use it in another metabolic disease with the just as a semi-graft, like a right lobe or left
this
lobe.
Is there any surgeon here, sir? Okay, so this is I talked maybe in Lisbon. There was a talk about surgical gene therapy. So this is surgical gene therapy. The first data came. I was in Alex Muaddi in London, that the head of pediatric hepatology, and it was the first day they present the data about surgical gene therapy by Professor Mohammed Rilla. So this is what they did. They call it non-donor liver transplantation. So they bring one patient with familial hypercholesterolemia and one patient of argenosuccinic, and then they switch the liver. The technique is an issue here, and until now, they already published 5-year survival. So actually, first you need the family to understand what's going on, because you know the problem if you failed, okay, then it's an issue. The good thing that you will go back to your primary disease. But the problem if you will affect the other liver also, because you will do the same like an auxiliary liver transplantation. And we know the data of auxiliary liver transplantation failed in many places because the blood supply will keep going to the native liver and there will be resistance. And then this part will be fibrotic. So there is very limited places they are doing this. I'm not aware about anyone in the state start to do this. The only one is Rilla, and he published his data. And now he's talking about 5 years. And they did 2 children from Oman in the recruitment with metabolic. And they are doing fine so far. But we never did it. Okay.
A period of time we can't identify, but after a period of time there is shift of blood to one of both loops, and the other one will be atrophied. And we have no clue what is happening. We don't know, but it is an observation that we saw in the patients we do for them do a liver transplant in adults. Yes.
I agree with you. We don't want to take the time. The topic need a lot of discussion. In 2004. I came to Sharm el-Sheikh and I met Millie Fergani. Those who know Millie Fergani, she was the head of pediatric liver transplantation in King's College. And at that time, we did in our center in military hospital 5 cases auxiliary, all of them failed. 3 of them were Crigler-Najjar syndrome, and 1 of them was factor 7 deficiency, 2 factor 7 deficiency. All of them failed within 2 years. And at that time, we have a German group working with our Saudi surgeon. At the same time, they publish in King's College their successful data about auxiliary liver transplantation in metabolic and in acute liver failure. So I asked her, what are you doing different from this stealing phenomena? And what she told me, she said, I don't know, surgically we are doing the same like you, but she did one thing. She keeps sending those children for portogram and doing blindly dilatation for the portal vein in both sides.
Yes.
And I think this is maybe the thing, but the problem who's the interventionist will accept to do portogram every 6 months and do blind dilatation for both portal vein. So actually, since that time, we didn't do any auxiliary liver transplantation.
Yeah, we always go back to our reference to Professor Poilot from Lyon, and he is always refusing to do an auxiliary liver. Just if acute liver failure, remove the liver and put a new one, no auxiliary. Yeah.
I agree with you.
Yeah.
Thank you, Professor Shagranji. It's time to present my dear colleague and friend, Dr. Mustafa Abdo, who is a professor of hepatobiliary surgery in Ain Shams University and the director of the liver transplantation unit in Nasser Institute, and he is the treasurer of the Egypt Liver Transplantation Society and has a very long experience with the liver transplantation, sharing in transplantation of more than 700 cases. It's your stage, Dr. Mustafa.
السلام عليكم. هو دايما انا بحس ان دايما بنحط السيشن بتاعت الجراحه في وسط السيشنز بتاعت الساينس هيباتولوجي just to keep the temperature of the whole a bit lower. Okay, our talk today about 3 parts: the stigma of liver replacement and the Egyptian journey, and our team experience. The stigma of liver replacement was the title of a paper published by Thomas Starzer himself in 2002. I think it is a very clever title. Stigma means a heroic tale, a heroic story that is narrated by the king about his victory. Okay, it's a very smart, very nice title. The story begins with Stuart Walsh in 1955, who published the first article in literature for liver transplant in a journal called Transplantation Bulletin. Nowadays, it is a transplantation journal. It is still publishing from this time. He described an auxiliary liver homotransplantation in dogs. He described an auxiliary liver in which he reconstructed the portal vein directly to the IVC, and the hepatic artery was anastomosis to the aortoiliac system, an operation similar to that in the kidney transplant. And for biliary drainage, he anastomosed the gallbladder to the duodenum. 1 year later, in 1965, John Cannon described the first attempt to do a liver replacement, and he published his paper in the same journal, the Transplantation Bulletin, with acknowledgement to Walsh himself by saying he did several successful operations without survival of patients. I don't know what kind of acknowledgement, but it is without survival of patients. 2 years later, Francois Maury, in 1958, he described the first orthotropic liver transplant in dogs. 5 years later, Thomas Starzer was successful to perform the first liver transplant ever for a 3-year-old boy with biliary atresia. 26 years later, Russell Strong has successfully performed the first living donor liver transplant using a left lateral segment from a mother to her son. All of this can't be done without the effort of Jean-François Bory, who discovered the cyclosporin from a natural fungal product. Cyclosporin increases the 1-year survival from 18% to 68%. What pediatrics granted liver transplant? Thank you for pediatrics. They granted us the first liver transplant ever and the first reduced disease donor, which opened the gate for the first living donor liver transplant that was done by Strong. The Egyptian journey started in 1991 with the first living donor liver transplant in Egypt in the National Liver Institute, under supervision with Dr. Yassin Abdel Ghaffar, Dr. Nagi Habib, and Ibrahim Marwan. Unfortunately, the results was not so good. So after 10 years, the breakthrough was in 2001 when two private hospitals, Dar el Fuad and Wadi Nil, started their living donor liver transplant program with the help of two schools, the Japanese school in Dar el Fuad and the French school in Wadi Nil Hospital. Again, what pediatrics bring the Egyptian liver transplant program, the pediatrics gave us the first transplant in Egypt in 2001 in Wadi Nil. The first pediatric, or the first case of transplant was a child. This team in Wadi Nil, from which all teams of Ain Shams University descend after this. So the success story started in 2001 with Dr. Ala Faiz and Dr. Tawhida Yassin Abdel Ghaffar, who succeeded together to perform the first team of transplant. Dr. Ala Faiz is a professor of hepatic surgeon. Later, he became the president of Ain Shams University. And Dr. Yassin is the professor of pediatric hepatology and the founder of Yassin Abdel Ghaffar Liver Foundation. From 2001 to 2012, they succeeded to transplant 74 cases in Wadi Nil and 7 cases in Ain Shams Specialist Hospital. Unfortunately, in 2012, with the sudden loss of Dr. Ala Faiz, the pediatric liver transplant program was suspended from 2012 to 2015. In 2015, we are back by the help and the effort of Dr. Amr Abdel Al. Dr. Amr Abdel Al is a professor of hepatobiliary and liver surgery at Shams University, and he is the head and the founder and the president of the Egyptian Liver Transplant Society and the secretary of the Pan-Arab Society, who was a member in the liver transplantation team that performed the first operation in 2001, and he created his own team, founded his own team from 2015, and by the help of Dr. Tawhida Yassin Abdel Ghaffar, they re-established again the pediatric transplant program. In 2018, we have a big share with Dr. Muhammad Al-Adawi, who joined our team. Dr. Muhammad Al-Adawi is a pediatric hepatology professor of pediatric hepatology at Shams University, and he is the head of the pediatric department in Saudi Germinal Hospital, Cairo. According to Egyptian medical records, from 2001 to 2016, 7% of the liver transplant in Egypt were pediatric cases. And the total number of pediatric transplants was 362 till 2022, from which Dr. Ala Faiz had did 81 cases in 11 years, and Dr. Amr Abdel Al did 140 cases in 8 years. This was under the umbrella of Dr. Tawhida Yassin and Dr. Muhammad Al-Adawi. This team transplanted till now about 61% of the pediatric transplant in Egypt, with a share from other centers in the form of 141 cases in this period, 21 years. Our team experience, we started our team in Air Force Specialized Hospital. It is one of the biggest military hospitals in Egypt in the mid of 2015. Few months later, in 2015, upon the request of the Ministry of Health, we started the center in Nasr Institute. It is the biggest governmental hospital in Egypt. 2016, we started another center in Kingdom Saudi Arabia in the Saudi German Hospital, Jeddah. In 2018, the owners of Saudi German Hospital, when they started their practice, their hospital in Egypt, requested to have another center in Egypt in 2018. 2019, Al Arabi Hospital joined our team, and in 2081, Islam International Hospital became under our supervision. We have two pediatric liver transplant centers, one in the Air Force Specialized Center and the other one in Saudi Germinal Hospital, Cairo. We have to notify that both centers are working under the protocol of the Ministry of Health, and they are fully funded for transplantation for free. We totally transplant till now 649 cases, 488 adults, and 161 pediatrics. 25% of our practice are pediatric liver transplant. The annual total number average 78 cases per year, and the annual pediatric cases of average 20 cases per year. 60% of our transplanted patients are males. The youngest was 7 months. 18% of our children was under 2 years, and 40% under 5 years. The lowest weight was 5.2 kilos. 18% of our patients are below 10 kilo, and the average MELD score was 13. Most of our patients receive grafts of between 1 and 4. We covered most of the spectrum of indication of liver transplant, and we are lucky to transplant 6 cases of acute fulminant hepatitis, 2 cases of glycogen storage disease, a single case of propionic acidemia, single case of Abernathy, and 2 cases of B-transplant. 50% of indications was for cholestatic liver disease, 13.5% were metabolic disease, and 5.5% of the indications were for hepatic liver tumors. Most of the grafts, as expected, are left liver graft in more than 95% of cases. We can add for this 2 cases of of combined liver and kidney, and 2 cases of domino transplant. The average graft recipient weight ratio was 2. The blood loss was 640 cc. The cold ischemia time 670 minutes, and warm ischemia time was 68 minutes with average operation time 8 hours. For biliary anastomosis, we use both techniques, duct-to-duct and hepatocogenostomy with a comparator ratio. Most of our patients have a single duct anastomosis in 96% of cases, and we adopted the technique of stentless biliary anastomosis in 87% of cases. For arterial anastomosis, about 78% of our patients has a single arterial inflow. For hospital stay, the average ICU stay was 7 days, and the average ward stay was 19 days. We have faced most of the recorded complication of liver transplant, but as usual, the biliary complications are the Achilles heel of the liver transplant. We had faced 23 cases of biliary anastomotic stricture and 7 cases of biliary leakage. And we are lucky that treatment of biliary complication was successful in 90%, either by pigtail insertion, PTC balloon dilatation, ERCP dilatation and stenting, surgical evacuation, or delayed bilioenteric reconstruction. The 1-year survival recorded in our cohort was 87 and 81 for 5-year survival, and the overall 3 months mortality was 8.7%. الحقيقة المقولة دي يعني أنا مش معرفلهاش مصدر، بس هي معناها إن لما يكون لينا معلم فده بيوفر علينا عمر، يا إما بتسأله في مشكلة فبيقول لك الإجابة أو بيدلك على الطريق، فهو يطيل عمرك بالمعرفة. فنحب نشكر الدكتورة توحيد ياسين عبد الغفار ودكتور محمد العدوي. Thank you for يعني giving us an extra life, and thank you all.
Thank you, Dr. Mustafa, for your comprehensive presentation.
It's a great pleasure to meet again for the last but not the least session with Professor Jerry Vockley. He's going to present 2 interesting topics also for their experience in Pittsburgh about liver transplantation for propionic acidemia as well as methylmalonic acidemia.
Being here to look at my second talk. If you haven't seen my first one, this will be a first. I'll be speaking on liver transplants for inborn errors of metabolism. So before we start the actual discussion about the inborn errors, I think there are some basic questions that we have to ask. First of all, as we're with focus on organic acidemias today, the question is, are non-life-threatening diseases candidates for transplant? Mostly these patients survive newborn because of newborn screening, unlike, for example, OTC deficiency. And so should we consider transplanting? How about is transplant a legitimate partial treatment rather than a cure? How should we best determine optimal timing for a transplant? And when does a benefit of a transplant outweigh the risk? If you think about options for metabolic therapy, you can break them down into several categories. Here you can see I have augmenting missing enzyme activity, which is of course where liver transplant could fall, reducing substrates either through diet or manipulation or pathway inhibition or redirection, and eliminating toxic compounds, which can be something like carnitine treatment or ammonia conjugating agencies, but also can be a liver transplant if you're just looking at reducing a toxin in the blood. So why would we consider a liver transplant in a metabolic disease? Well, number one, it could be life-saving. So OTC deficiency, you unequivocally can get these individuals to survive, whereas at least with the severe males, otherwise they're going to die before a year of age. They are life-altering, and that can be discussed or thought of very, very broadly, and most importantly, they can be life improving. So even if you don't cure the disease, if you make the patient's life better, it's of value. How do you decide on that value? Well, you have to look at mortality and survival in the context of liver transplant, morbidities of the disease, morbidities of non-transplant therapy, the effectiveness of non-transplant therapy, and the impact of morbidities on quality of life. So it's a bit of a complicated equation. And I'm going to start by showing you some data on a couple of disorders where there really is no argument about whether or not a transplant should be done. Let's look at MSUD first. So on the left, you see, excuse me, the outcome of patients with maple syrup urine disease pre-transplant, and almost all of the patients are down in the quartile where there is reduced either adaptive or IQ scales with adaption. Meaning a reduction in function, typically not measured by IQ, so younger individuals, much like a developmental quotient. If you look at the age of transplant, what you can see is that both the adaptive score and the intelligence quotient, the IQ in patients, tends to be pretty evenly scattered. There are some that are above 100 normal in the usual scales, but they actually don't change very much over time. But the vast majority of them are much lower. What happens if you transplant them? Well, you at least stabilize them. And in some cases, here looking at individual patients, you can increase their IQ or participant. But at the very least, you're stabilizing them, which in this disease is a good thing. let's look at urea cycle disorders. The cognitive outcomes in non-transplanted patients aren't all that good. If you look at overall either neonatal onset or late onset, you can see early onset, only 20% of patients are viewed as being of average cognitive ability. Later onset, it's a little bit better, but still a third of patients are not above average or at average cognitive ability. If we look at it with in terms of diagnoses, what you can see is that mild disorders or mild OTC deficiency, you can have average outcome, though the severe, this is very unusual. In all comers for AL and AS deficiency, only about a third of those patients have average outcomes. So this is not a good outcome. And we have to just talk about whether or not we should be doing something in those cases. And this is more than just all or nothing. It's not just preserving life; it's preserving outcome. And if you have something that can give someone a better quality of life, it's worth considering. So what does that look like for metabolic liver transplants? Well, at Children's Hospital in Pittsburgh, we're the leading metabolic liver transplant center in the United States. And here looking over roughly about 40 years, you can see we've done 400 metabolic liver transplants. The MSUD is the largest number of those. Urea cycle are quite high, as is tyrosinemia. This is alpha-1 antitrypsin or antitrypsinogen deficiency. This is gets lumped as a metabolic disease in these analyses, but is probably not really what we're talking about today. What's the outcome? Well, if you look at individuals who have systemic or have symptoms that are limited to the liver, not surprisingly, these individuals do better than those who have systemic problems. Similarly, it's probably not surprising to look at the graft survival and patient survival, and here in aggregate you can see that the patient survival is it's about 88% across. Now this is the last 30 years and not 40. But if you break that down by decade, it's much better since the turn of the century than it was beforehand. And so with survival that looks like this, and I'm sorry, I covered up this is 100%. So this is about 95% or 97% in this decade or in this century. You really are now start looking at this as other than just a last ditch therapy. So let's turn to methylmalonic acidemia and propionic acidemia, the two most common organic acidemias for which liver transplants occur. So if you look at the natural history, there's significant morbidity and mortality in spite of the current standard of care medically, which is really dietary manipulation plus or minus some other medical manipulations. The benefit, potential benefit of a liver biopsy, and what we've seen, and I'll show you this over time in doing these transplants is it unequivocally reduces the frequency of metabolic episodes. It's not zero, but it's pretty close, and most patients do very, very well. It improves the cardiomyopathy that's unique to propionic acidemia. It improves protein tolerance, and so allows patients to come back to close to a normal diet. And there's a significant neuroprotection. It's not 100% again, but it's pretty good. It's reportable to have a metabolic stroke after a liver transplant as compared to before a liver transplant. Now, residual problems, there's still a little bit of a residual chance for metabolic stroke. Some patients probably still need some protein restriction. And across the board, there is a little bit of an increased risk for pancreatitis in these patients, that regardless of the liver transplant, probably related to endogenous dysfunction, mitochondrial dysfunction in the end organ here. And of course, what I haven't said here is that you have a potential issue with infection due to chronic immunosuppression. Well, let's look at some of the outcomes here in Pittsburgh. And what you can see is quite a number of MMA transplants and serum glycine levels, a surrogate marker for MMA level, drop significantly after transplant, and serum methylmalonic acid over here directly measured drops significantly as well. Episodes of hyperammonemia and level of serum ammonia. You can see a whole number of measurements here. They are statistically lower both before or after in both propionic acidemia and methylmalonic acidemia, and lower in all in the combined PA and MMA for serum ammonia. And then serum transplant. Serum lactate post-transplant, again in PA, is significantly lower. MMA, early MMA, it tends to be a little higher, and in late MMA, it drops. But it is if you look at all of the MMA patients, the level of ammonia or lactate rather drops across their post-transplant course. What are these? What does this look like in terms of other outcomes? And here you can see a detailed description of 9 patients, and you can see here episodes of rejection. Some individuals have episodes of rejection. In fact, most of them do. Some don't. These are easily handled with a burst of steroids. Biliary stricture is one of the more common problems, requiring some post-transplant intervention usually. And most of the patients either have not had their EKGs characterized or were normal, and there were 3 who had mild abnormals in. I'm sorry. This is I got this wrong. This is QT interval. The cystatin C levels are all normal in these patients. All of them are on some level of dietary restriction, though they have some relaxation on the order of 1 gram per kilo per day of their protein. And then carnitine supplementation, we just tend to keep everybody on it. And then you can see we have anywhere here, this was published already now back in 2018. All of these patients are still alive, so you can add another 5 years onto the total follow-up and at the age of last follow-up. One of the other advantages to working in children is that we can do living-related donors. In the case of metabolic disorders, these can, it turns out, be the obligate heterozygote parents. It can also be living unrelated donors, as long as there's a good enough antigen match. And you can see here a summary of now this is not just our patients, but a review of the literature, the number of subjects that have been done with living related donors, and it's quite a large number. This adds up to looking at it here, probably around 400. The bottom line is that these patients actually do quite well, and you can see down here the organic acidemias, as I mentioned, the risk of metabolic crisis significantly reduced. MSUD, the risk of a metabolic crisis inducing cerebral edema and coma is almost zero in this disease, and you can see the other ones here and the reference if you want to look that up on your own. The main focus here today on organic acidemias brought out highlighted here, so you can see that 63 have been done. And I don't even remember what the columns are. Let me go back one here. There we go. So that second column is age in months. So 7 to 90, and follow-up duration 1 to 161. And heterozygous donors have been used here, so it's a good option to consider when organs are limiting. Now, one of the really interesting aspects of using or transplanting some of these patients with organic acidemias is that you can actually use the liver in a different disease. And so, for example, we have routinely used MSUD donor livers. They're being transplanted from either a living related donor or a deceased donor. You take, depending on the size of the organ, either the whole organ or do a split, and you can transplant this into a patient with MMA and PA. Now you say, well, why don't they get MSUD? Because these patients have normal branched chain Q acid dehydrogenase in the rest of their body, so that takes care of the leucine metabolism. And you provide them with the same amount of either propionyl-CoA carboxylase or methylmalonyl-CoA mutase activity as you would just a deceased donor liver, and these patients do quite well. In fact, there might even be some benefit here because you decrease the substrate through the branched chain pathway, and so you decrease organic acid load just by virtue of having an MSUD liver. And you can see the disorders where a domino liver has been used. Here's some information on the follow-up of these patients. So you can see here, this is a 2019 publication. So add another 4 years or 5 years on top of this. Follow up 2 to 3 years. The age of the non-MSUD recipient, these have largely been older patients, the MSUD donor, also largely older patients. Normal isoleucine and valine in these the patients that have received the MSUD liver. Most of these are on a regular diet, and they have normal liver function tests. Check my time here. We need to wrap this up. So what other conditions or what other considerations are there as we look for at this possibility? Well, for PN and MMA, well, actually MMA, you need to consider isolated liver versus liver kidney because MMA patients can have a kidney disease. And so if they have current kidney disease or a predicted course that's going to lead them to renal failure soon, you would do a combined kidney transplant versus somebody early on in their disease where you would do an isolated liver transplant. That appears to slow down the kidney disease, but it doesn't stop it. But it gives you, maybe another decade before you have to do that first kidney transplant. If you're going to look for a living-related donor, a non-carrier is ideal, but you can do a parent, and you can also do, as I described, MSUD patients as a domino donor. Just keep in mind that for organic acidemias, especially propionic acidemia and methylmalonic acidemia, where these have been used considerably, transplant's not a cure. They may still need some diet. You have to watch out for those symptoms that I talked to you about before. And then consider whether or not they need other adjunct therapies. There may be some clinical trials coming down the road that where these patients can be still be considered as subjects because they can potentially affect the propionate methylmalonate metabolism in the rest of the body. Gene therapies are in the early manifestation are likely to be liver focused, and so you have to have at least as good a liver expression as you do in a normal liver, presumably to make this work. And then ultimately, if you can get expression in other tissues, you may be able to have lower levels of liver activity. So where do we go next? Well, I think the bottom line is that we're going to have multiple options. And you're never going to be thinking about doing a single therapy, but look at what's available to you across the spectrum. One of which is going to be liver transplant. Liver transplant is here and now. Most of the other therapies we're talking about, short of dietary manipulation, could be 5 to 10 years in the future. And so your families will have to make that determination of whether or not a liver transplant is for them. And rethinking the paradigm of using liver transplant as a way of improving disease rather than just curing it is in order because liver transplant outcomes are so good. So with that, I'll just thank you to my lab and my clinical research team, and be available hopefully for questions at the live Q&A. So thank you for listening to this talk.
Okay, we have, because of the late time, we have 2 questions. The floor is open now. Dr. Mohammed, Dr. Shagrani. Thank you very much for your great presentation. Okay.
بسأل على الدومينو ترانسبلانت بس ليه الام اس دي اللي بتحط في النص الستيب وايز وازاي بتحصل؟ مش فاهم.
The MSUD graft is totally normal graft. The protein restriction is not affecting the liver. This is one thing. The other thing, the enzymatic replacement of the MSUD is enough from the other organs. And when you give an MSUD graft in another patient, the enzymatic replacement will come from his kidney and his muscle. And this is the reason, like, they start by giving it to adult, and then they observe the adult, and they look for the isoleucine and leucine. And just to be conservative at the beginning, they put them in protein restriction, and they found there is no need. Their leucine and isoleucine normal, even though they have an MSUD graft, because the enzyme coming from the kidney and from the muscles. This is the reason when you wanted to use a recipient to take MSUD graft, you don't choose an adult with renal failure or with muscle disease. Then he will manifest the disease. But this is the reason the MSUD graft has one of the graft used as domino. And now, as you see in the talk, they are start to use MMA, but we never did.
Just I want to ask for, you said for sometimes if you, for the severe genotype, if you do have a severe type, you start early, for example, PA. What is, at what age did you start? Just to give a chance to see for newly delivered baby. If I do have one index case severely affected, I do have even if he died, and then I do encounter another one. Could you tell me from your experience?
We transplanted OTC 6 weeks, and we transplant now most of the PA, the recent PA, all of them below 6 months. So we start now to recommend all of our metabolic doctors, if you know the phenotype, because this is the patient which really you wanted to invest. Professor Jerry was talking about improving quality of life. Still, this should be considered. And at the end of the day, when the parents come to you with a metabolic child, even if he has seizure, he's an anti-epileptic, but still he has some function. Yes, he will end to be low IQ, but at least he is motorly mobile. So the lifestyle of the family will be different. Still, we are offering them the transplant, but it will be much, much better if you choose those patients while still below 1 year. And even the brain development still has time. We know that those above 6 months, still up to 1 year, still you have a brain development, and maybe you will cover a lot of the effects. Even though, if you look to literatures, people talking about one single attack of ammonia, more than 500, is enough to cause brain insult. But you cannot know the severity or the degree of this brain insult. So yes, as long as you have a good surgeon that can deal with the small patients, and you will do left lateral, and you need to deal with closure. Because whenever you do those metabolic patients at the age of 2 weeks, 2 months or 3 months or below 1 year, most of the time the graft ratio will be bigger than the child, and this child will stay with open abdomen at least 7 to 10 days. So yes, there is a lot of things to deal with, but those they will have the best really outcome comparing with others.
Because, regarding MSUD, I do have one patient who had elder child with a severe phenotype, and I really, for the second baby, delivered at day 1, I started dietary management perfect, and now 6 years without anything. This is my question. My question, not I knew that for early OTC and early CBS1, those are the severe, and we have to start because we don't know, even with good control of dietary management, you can't, as you said previously, that you don't anticipate what will be the attacks even with good control of diet.
You know, the MSUD is totally different. Yeah, the MSUD sometimes, we transplant MSUD 17 years old.
Yeah.
Most of the data about the MSUD, those who they didn't do well, they were not treated actually or diagnosed earlier. But yes, if you diagnose them earlier, most of the time you will send them when they are in the first or second decade of life because you cannot control their diet.
Yeah.
This is the difference. When they are younger, it's easy to control their diet. So the MSUD is totally different from PA and MMA and OTC. Yes.
Okay. Thank you very much.
I want to stress for the young doctors on something that patients at Dr. Vockley presentation will restrict the diet after transplantation propionic acidemia to 1 gram per kg per day. And we have some patients already with the dietary control on 1 gram per kg per day. So the aim is not to increase the protein intake to 1.5 or 2. The aim is to decrease the attacks of decompensation that will result in brain affection, and it will result in bad quality of life. So when you consult the patient, it is not our aim to have free diet or relaxed diet, because our patient with propionic acidemia have genotype better than Saudi Arabia, so they can tolerate up to 1 gram, sometimes 1.2 gram per kg per day. Thank you. بيقول لو حد عايز يسأل. Is there any question? Please, Dr. محمد.
بس نفس السؤال يا دكتور، هل البيشنتس اللي عند حضرتك في الكينج فيسر كلهم مشوا على بروتين ريستريكشن مثلا نونيك او البروبيونيك؟ ان عيال بيسالونا فاكرين انهم يعملوا ريد ليفر ترانسبلانتيشن ان هم خلاص هيبقوا فري بروتين ريستريكشن. kept in protein restriction. Yes. Okay. Thank you.
Another question in the patients with propionic and methylmalonic acidemia, during surgery, you give L-carnitine 100 gram per kg. Although this is a stressful condition, and we usually in the hospital we give up to 200 or 300.
I mean, we didn't really do difference. So I have this question when I was in Lisbon, what did you do difference? Because still our data in PA better. I need to admit we have an excellent surgeon, and this is make difference because, you know, those patients fragile, if they will have bleeding, if they will be hypovolemic during OR, during the anhepatic phase. So whenever the surgery is smooth, you don't need to do a lot. So we didn't do anything. We didn't face any case that really required infusion. But we keep them on the same dose because most of them on total dose of 100 milligram per kg, we move it just to IV during all the phase while they are in the ICU until they will be shifted to the ward. If you look to the data, I think most of the data is very conservative because people did one case here and one case there. If you look for data coming from Asia, all of them, even they will have a meeting with the anesthesia to decide some medication not to be given for PA or MMA during the surgery because they are thinking that some of those medication has been reported a long time ago that it will cause or induce crisis in those patients. We did this in the first two cases and then it's really no need.
And you give glucose 10% all through the operation?
Yes, this is very important. And as we move, we observe this also in glycogen type 1A because those patients can develop very high lactate and metabolic acidosis intraoperatively. So we found giving them insulin was the best way of management. Insulin with sugar.
Glucose. Yes.
Absolutely, because they manifest as a catabolic, so you push them to anabolic. So giving sodium bicarb to correct their acidosis, they will end with hypernatremia and brain edema. So those glycogen type 1A, if they misbehave intraoperatively, if there is bleeding or stress and they lactate high and they have acidosis, In 2 of them, we immediately have a protocol of insulin infusion or boluses with high dose dextrose and you reverse the acidosis.
Also the same for MMA, PA and MSUD.
Yes, if they need.
If they need. The last question about gene therapy for MMA. In Saudi Arabia, do you have started the clinical trial for?
They didn't start anything. I mean, Dr. Ula was with them. Until now, none of the OCDs or UCDs are started. We have been approached for the gene therapy for Crigler-Najjar syndrome. But with our situation, family, they are not interested, and all of them wanted to go for transplant. But not in the OCDs. Yeah.
Okay, any other questions? Okay, thank you. And last but not least, Dr. Ahmed Iskandar from Nutritia, Egypt, will present 10 minutes talk.
So hello all, thank you very much for staying this late. It will be very concise. I will take almost 4 minutes. And it's always hard the most to speak in University Congress because most of you, we talk your talks as a citation in our presentation. So it's very hard to do any talks now. My name is Ahmed Iskandar. I am the Medical Science Liaison for Metabolic and Ketogenic for MENA region. And we will talk quickly about nutrition because as I told you, it's very hard to talk medical with your presence. So starting with Nutritia, we are part of Danone company, the very big Danone Diverse World company. Part of Danone is Nutritia, the medical formula company or the medical nutrition company. We present in 100 countries around the world and we do have a wide portfolio starting from infancy till elderly. Starting with 1896 with the first infant formula, going to the pre and probiotic and HMO in 2023 and 2024, and all of this including also the metabolic formulas that we have that are supplemented with the prebiotic, the GOS and FOS, the 1-to-1 DHA and DAA. We are trying all the time to give the state of art when it comes to growth, even in our metabolic portfolio. Growth and development, healthy protection and immunity, enhanced recovery and support the healthy aging. All of this have been our goals developing our clinical nutrition portfolio. Across the MENA region, we have worked in the immunity, in the gut health, in the allergy, filtering growth, metabolic, epilepsy, oncology, and ICU. This was not only supported by our own research. We do have more than 136 peer-reviewed papers published. We do have 64 engagement in scientific conferences in 2022 and 2023 alone. We also have 18 publications that is real world evidence from the Middle East. والرقم ده السنة دي زاد ل 20 publication طالعين من الميدل ايست كلهم real evidence من جوه الميدل ايست، مش بقينا نعتمد بس على الحاجات اللي جايه لنا من بره. Last thing, as a Nutritia, we see you as an HCPs as doctors في الفيلد. انتوا الفيرست لاين دايما مع البيشنت. We are trying to support you with innovation solution, evidence-based science, complete portfolio من البرودكت اللي يقدر يساعدكم مع امراض مختلفه, face-to-face detailing, educational websites, medical congress, digital tools. One of our unbranded website, Nutritia Middle East او Nutritia Campus Middle East, هتلاقوا عليه webinars وهتلاقوا عليه different resources و different materials. It's fully unbranded website.
At Nutritia, we believe in the power of nutrition to improve health from infancy to old age. Because our partnership with healthcare professionals in this journey is key, Nutrition aims to grow knowledge through education and learnings.
Right. We also provide in the Middle East a complete portfolio of nutrition solutions للmetabolic conditions من أول MCOD, PQ, HCU, MMA, BA, UCD, high branch chain amino acid, high MCT formulas. We are trying with your support طبعا to have all the coverage for all the patient. In highlight بس لكل التوكس بتاعت النهارده, our formulas for the MMA BA is the MMA BA Anamix Infant, which is the formula from birth till 1 year. which is طبعا ميثونين ثايونين فالين فري ولو في الايزوليوسين powdered formula. Also here in Egypt the above 1 year formula we do have is the XMTVI, and to remember the name X mean it doesn't have methionine, thionine, valine and low in isoleucine. You can see in some other country we do have the MMABA Anamix Junior, but currently our portfolio in Egypt is the XMTVI Maximate for the above 1 year. Yes, that's it. Thank you very much.
Okay. شكرا دكتور احمد، وانك عملت الشورت فيري شورت توك. وكده احنا بننهي المؤتمر. بنشكر طبعا جميع السبيكرز والاودينس ان هم صبروا لغايه الساعه 8 وشويه. وناقص بس حاجه اخيره دكتور شجراني، بس حاجه بسيطه احنا
شكرا.